Good evening, everybody. So, welcome to the 48th Journal Club, I think 40th or 48th, which we have been doing for the last now close to 4 years. We started in September 2022. So, today we have a very, very interesting journal article, which is teclistamab plus daratumumab in relapsed refractory multiple myeloma, which was published during the when the ASH was going on in Orlando. And for presenting this journal club, we have Dr. Farhan Naeem from Max Super Specialty Hospital. Our experts today are the international expert, Professor Luciano G. Costa, who is the first author on this paper, and we are very happy to have him here. The national expert is Dr. Riaz Ahmed from Max Super Specialty Hospital. So the journal article would be presented by Dr. Farhan, followed by a discussion, and then we will have the eagle eye competition, and will be taken over by Dr. Sumit. Thank you so much, and over to Dr. Farhan Naeem for the Journal Club presentation.
Recording in progress.
So, very good morning, good
Recording
evening
stopped.
to everyone. I am Dr. Farhan Naeem. I'm working as a senior consultant at Max Super Specialty Hospital, Saket. So, today I'm going to present today's journal club for the image today, and let me just share my screen. The article for today's journal club is the teclistamab plus daratumumab in relapsed refractory multiple myeloma. It was published in NEJM in December 2025, and it represents the MajesTEC 3 study. So the frontline multiple myeloma therapy has dramatically improved. However, once patient relapses, the subsequent response durations are significantly less. And this is the place where we desperately need a drug which can take care for this. So we need more effective treatments for patients whose disease progresses after frontline therapy. The teclistamab, a bispecific antibody targeting BCMA and CD3, has demonstrated deep, durable responses in heavily pretreated relapsed refractory multiple myeloma patients in the phase 1-2 MajesTEC 1 study with improved efficacy and safety in heavily pretreated patients. Daratumumab is an anti-CD38 targeting monoclonal antibody with demonstrated survival benefit across all lines of treatments. So the teclistamab daratumumab is a synergistic immunotherapy-based therapeutic strategy with the potential to improve outcomes in two-line plus relapsed refractory multiple myeloma patients. So coming to the mechanism of action, so we know that this teclistamab daratumumab is a synergistic, works in a synergy. So the daratumumab primes the microenvironment by clearing immunosuppressive CD8 positive Tregs and Bregs in addition to Dara's direct on-tumor effects. So this teclistamab daratumumab activates CD positive T cells for sustained immune enhancement, and teclistamab redirects activated CD8 positive T cells to effectively kill multiple myeloma cells, and this is how they work in synergistically. Coming to the study design, it's a phase 3 randomized multicenter open label study of teclistamab in combination with daratumumab versus DPT or DVD in the patients of relapsed refractory multiple myeloma. It was conducted in 150 sites across 20 countries. So the patients were relapsed refractory multiple myeloma who has received 1 to 3 prior lines of treatment, including a proteasome inhibitor and lenalidomide. Patients with only one prior line of treatment must have been lenalidomide refractory, and the performance status 0 to 2. So the exclusion criteria was primary BCMA directed therapy, refractory to or patients who are refractory to the anti-CD38 monoclonal antibodies. So they were randomized in 1:1. Total numbers was 587. Study was from October 2021 to September 2023. So as you can see in this tag data, the number of patients was 291, and those in DPD or DVD, it was 296. The predominant population was of the DPD, which constituted around 91%. So the endpoints, the primary endpoint was the progression-free survival. The key secondary endpoints were CR rates were better and overall response rates, MRD negativity, overall survival. There was a questionnaire-based total symptom score, and other secondary endpoints included the safety and the pharmacokinetics and the immunogenicity. Coming to the study design, that how the drugs were given, it was a 28 days cycles, and cycle 1 included weekly dosing of teclistamab. After the step-up dose, it was 1.5 milligram per kg every week, and daratumumab was given as a standard dose of 1800 milligram every weekly. So it was given same way in cycle 1 and cycle 2. From cycle 3 to 6, the teclistamab dose was doubled to 3 milligram per kg, but it was every 2 weekly. And the same dara was same dose every 2 weekly. And from 7 cycles onwards, the teclistamab was 3 milligram per kg every 4 weekly, and daratumumab was 1800 milligram every 4 weekly. So DARA was the standard dose, and teclistamab dose was adjusted to give both the drugs together, and the ease of administration, it was all both for the subcutaneous administration. So one important point to highlight here is that dexamethasone pre-medication was required first 2 weeks only. Coming to the demographics and disease characteristics, so we can see it was balanced in both the groups. The median age was 64 years in TEC-DARA and 63 in DPD or DVD. So age of the patient elderly population was equally distributed, but it was overall less, 10.7% in TEC-DARA group. The sex distribution, race, performance status, they were well distributed in both the groups. ISS stage 3 was the number of patients were less, but it was distributed in both the groups. And coming to the high risk cytogenetics, it was around 36.5% in teclistamab group, and around 35.4% DPD and DVD group. Coming to the prior lines of treatment, so the again they are equally distributed the patients in both the groups. So patient who received 3 lines of treatment, it was around 16% in both the groups, and the prior transplant also almost same in both the groups. Prior PI exposure, prior IMiD exposure, prior anti-CD38 exposure was only 5%, nearly 5% in both the groups. It was less, which is not the scenario nowadays. So coming to the refractory to any PI, refractory to any IMiDs, they were equally distributed, and double refractory patients were also. Now coming to the patient disposition. So the median follow-up study was 34.5 months. The 587 patients were randomized. 291 received TEC-DARA and 291 received TEC-DARA and 296 received DPD or the DVD. So among the patients who received DPD or DVD, the DPD was 90.7% and DVD was only 9.3%. So at the clinical cutoff point, total 283 patients remain on treatment, and among the TEC-DARA group, 71%, and among the DPD or DVD, they were only 28.3%. So median treatment duration in TEC-DARA was 32.4 months, and DPD was 16.1 months. So despite there were many interruptions in the treatment in TEC-DARA, but still they received more treatment. And coming to the discontinuation rates that the table below shows. So in the TEC-DARA group, it was significantly less than in the DPD and DVD, and the reason was the most of the time is the disease progression in the DPD or DVD group. So now coming to the progression-free survival at the median follow-up 34.5 months. So the median PFS was not reached for TEC-DARA group, and it was 18.1 months for the DPD or DVD. And you can still see that at this clinical cutoff point, the PFS of nearly 84%. And the Kaplan-Meier curve, they look beautifully separated out, and they prominently show the very high efficacy of the trial drug here. So coming to the PFS subgroup analysis. So as you can see, the benefit of TEC-DARA was in the PFS as seen across all the subgroups. So now coming to the treatment response and response duration. So the overall responses are high in both the groups. It was 89% in TechDara and deep in 75% in DPT and DVT. But if you see the stringent CR or the CR rates, so it was significantly high for in the TechDara group was 77.3% versus 23.3%. Again, if you see the MRD negativity rates, so it was significantly high. It was 58.4% in Tech Dara group and only 17.1% in the DPT or DVT group. So this is how it shows the very high, the very good and high response rate. The overall response rates are very high and the patient achieving MRD negativity is very high in Tech Dara group. So coming to the overall survival, so median OS was not reached in either treatment arm. So if you see the Kaplan-Meier curve, it separates after the 10 months. So the initial high increased mortalities which was seen with Tech-Dara group was because of the infections. And I will discuss in the later slides that how the change in the protocols of giving the IVIG has decreased it significantly. But now if you see the Kaplan-Meier curve, so the with the Tech Dara group, 92.2% of patients were alive at 6 months and 84.3% at 30 months. So now the graph is plateauing for the Tech Dara. So at 36 months, around 83% patients who are 84% patients who are still alive and they're doing well, and the graphs are plateauing. This is a drug which a disease which was till now considered as a non-curable, but with the drugs like this, we can see how after the 3 years and the patients, the graph of OS is plateauing now. Coming to the total symptom score based on the questionnaire, the median time to worsening of multiple myeloma symptoms was not non-estimable with the Tech Dara versus 39.9 months with the DPD or DVD group with the hazard ratio 0.5. The 36 months event-free rate was Tech Dara, it was 75.6%, and with the DPD or DVD it was 63%. Coming to the overall safety profile, so it's very important now to discuss because once we have this drug which we have seen that it's very highly efficacious, so what is the safety profile, and especially we'll discuss later the infection profile also. So the hematological toxicities of grade 3-4 was quite common in both the groups. It was 75 points grade 3-4 hematologic toxicity, neutropenia, especially neutropenia. Grade 3-4 was 75% in Tech Dara group and was 78.6% DPD and DVD, and the overall the hematologic toxicity of grade 2 was significantly high in both, but they most of the time they are easily manageable. Coming to the non-hematological, so the hypogammaglobulinemia, it's very important. It was seen in 68.6% patients in Tech Dara and 35.9% in the DPD or DVD group. And next, coming to the cytokine release syndrome. So the one important thing to focus here. So it was there. It is not seen in the DPD or DVD, but it was there in Tech Dara group. But if you see the how many patients, it was 60.1% patients have had the CRS, but all were grade 1 and 2. So grade 3-4 CRS was not here. And the other side effects, you see the infections, they were higher, many were higher in the Tech Dara group. You see the COVID-19 because it's trial conducted in the COVID-19 era. So the COVID-19 patients, the infection was higher in Tech Dara group, the COVID-19 pneumonia in 12% of patients versus 4.1% of patients in DPT and DVT. So this is the point which need to discuss further is the infection. So the new onset grade 3 or more infection decreased after 6 months of treatment. As we saw even the mortality, it was seen initial mortality in the Tech Dara group because of the infection, but that significantly that is start decreasing once after the 6 months of treatment. So once the monthly dosing comes, then the infection rate significantly decreases. It coincides with the transition to 4-weekly dosing. The incidence of grade 3-4 COVID-19 related infections was higher in Tech Dara versus DPT DVT. The COVID-19 infection 6% versus 2%. The hypogammaglobulinemia occurred in 84.5% is in Tech Dara and 60% is in DPT or DVT. So this is significantly high. The before reinforced guidance on the IVIG infusion, fatal infections occurred in 12 patients in Tec-DARA group and 2 patients in DPT and DVT group. But after reinforcement of the guidelines, the fatal infection occurred in 1 patient in Tec-DARA group and 2 patients in DPT and DVT. So I think one of the important intervention which can decrease the infections is the IVIG infusions. Coming to the secondary primary cancer, so a second primary cancer was observed in 12.4% of patients receiving Tec-DARA and 8.6% patients receiving the DPT or DVT. The most cases were subcutaneous and non-invasive. If we exclude the cutaneous and non-invasive cases, the incidence rates of other secondary cancers were balanced between the two groups. So just some discussion about this article. So we have seen that the treatment of relapse refractory multiple myeloma is increasingly challenging. The emerging treatment options include the novel BCMA targeting therapies and the BCMA targeting CAR T cell therapy. So the teclistamab and daratumumab is a synergistic immunotherapy which has a very high efficacy as we have seen, with only low-grade CRS, but infections remain a concern. The Tec-DARA group with 83% reduction in the risk of disease progression or death and 84% patient still alive at 36 months and follow-up is promising. So there's some small comparison with what available to me with the other BCMA products we have. So we have Dara and teclistamab, which we have seen in the Majestic 3 study. We have Cilta-cel, we have Valentamab. So if you see all these, so it's this slide is plotted, so it not be very visible. So I can read out the salient things is. So in all the studies, if you see in all these bispecific antibodies, so anti-CD30A refractory exposed, they were high in the Cilta-cel group, and in the Majestic 3 it was less. So refractory patient was 0% and exposed patients were only 5.2%. So coming to the higher risk cytogenetics, it was significantly, we can see the high 59.4% in the Cilta-cel trial. So this is another important point I can highlight here. And coming to when we come to the response rates, the overall response rates, they are the 3-year PFS of 83% is significant. It's very high if we see compared to the other 1-year PFS. It was 76% with the Cilta-cel and 1 year 78% PFS with the Valentamab. And more important is the hypogammaglobulinemia was significantly high in the Majestic 3 study with the teclistamab. But if you see the all CRS all grades, so it is less in fact with the patients of teclistamab, not reported in Valentamab, and the ICANS but high in the Cilta-cel. So there are some minor differences between the different bispecific antibodies, and we have to choose or decide accordingly once we have more data available where we can see. In fact, the head-to-head trial among the bispecific antibodies, if available, will really help to find out the differences and a better drug which we can decide. So nearly all patients in the teclistamab and daratumumab group had a grade 3 or higher adverse event, with 7.1% dying from the adverse events. And so the most important point here to highlight is the CRS was well manageable. It was only grade 1 and 2, and nothing requiring any special intervention, and all were mostly during the step-up dosing. But the hypogammaglobulinemia was in 84.5%, this is in Tec-DARA, and 60% patient in DPT and DVT. And these events can be controlled with established immune globulin therapy, as we saw. The mortalities which were initially high in the Tec-DARA group was significantly decreased once the IVIG infusion protocols were implemented. So once we implement this infection prevention protocols, so we can easily administer this drug. We are the concern which was there about the infection can be easily managed with the IVIG infusions. So just concluding my talk is that patients receiving teclistamab and daratumumab had significantly longer progression-free survival with a plateauing curve after the 6 months. The 83.4% PFS rate at 3 years with benefit across pre-specified and clinically relevant subgroup. The OS benefit and the graphs getting plateauing after the 3 years and 64% patients surviving, it's really promising. The grade 3 or more infections were highest in the first 6 months and declined over time. The support with infection prophylaxis monitoring and established IVIG supplementation protocols decreased the infections. So coming to the few limitations that I will discuss, which I observed is the trial environment began during the COVID-19 pandemic. So thus infection profile was different. So there was time more strict isolations and the mask guidelines were there. So the infection, the profile might be different now if it is implemented now. So second and very important is the low risk of low number of patients with prior anti-CD8, CD38 exposure. So now in the subgroup, which is now available as the more exposed patient to the anti-CD38, how the results would be that we have to see. And the smaller population of the patients aged 75 or years or more with an ECOG performance status of 2, this was represented with a smaller number. So these are the few with limitations which I can find out, but still we have a drug showing very high efficacy. The concerns of infection can be managed easily with the IVIG protocols and that with the prophylaxis, tocilizumab prophylaxis, the CRS rates, those significant in this, but all were grade 1, 2 and easily manageable. And they can, I think, further be reduced with a more strict prophylaxis with the tocilizumab. So thank you.
So thank you, Farhan. So over to, I think that Costa has joined us.
Yes, he's there.
Okay, Dr. Costa, greetings. I think it must be good morning there in Alabama.
Good morning. How are you? Thanks for having me.
Yeah, so we would like to have your comments and the nitty-gritties of of the trial and the nuisances, which sometimes we do not discuss in the article. So if we can have your expert comments on that, and then we have our Indian expert, Dr. Riaz Ahmed, and then we have some question answer sessions from the audience.
No, absolutely. I think all the key points were very well made. This is, of course, a very important trial. I think it's the first trial with T-cell redirecting therapy in a phase 3 that is more immediately scalable. I mean, the data you had up to this point was with CAR T-cell without the limitations that we have in terms of access and scalability. So for this reason alone, this is a very important trial. I think we had, to me, this trial is going to be remembered as, to me, as a trial that changes the perception about bispecific T-cell engagers. I think if you look at the data for CARTITUDE-1 and KarMMa, and then MajesTEC-1 and MagnetisMM-3 and so forth, there was this perception that bispecific T-cell engagers are lesser therapies than CAR T-cell. And I think a lot of that has to do with patient population and how those trials are conducted and how we define the denominator on those trials. But when you look at phase 3 to phase 3, when you look, for example, MajesTEC-3 compared to, for example, CARTITUDE-4, or MajesTEC-3 alone, I mean, it's hard to tell that this kind of efficacy data is second to anything, right? So now when I approach patients with 1 to 3 prior lines of therapy, I no longer think of bispecific versus CAR T in terms of having an efficacy difference, as those decisions often become about patient preference and the compromises that there are of which one of those therapies. I think we are all surprised by the efficacy. We also surprised by the safety. I think there was some early signal about anti-CD38 antibodies and BCMA T-cell engagers having a very high infection signal. And what we saw in this trial, we often, we do randomized trials, of course, to compare efficacy, but we often overlook the context that the control arm provides for safety as well. And when you see at the end of the day, the number of the incidence of high-grade adverse event was not much different. Discontinuation due to AE was not much different, and fatal AE was not much different. Now, if you zoom in an infection, there is indeed a signal. There's a very nice graph that unfortunately did not make to the manuscript that shows the rate of infection for each 6-month block. And essentially, it's higher for TECDAR on the first 6 months, and beyond 6 months is essentially equates to the rate of infection that you see on DPD or DVD. So that reminds us the most infection prompting factor in a myeloma patient is disease burden, and the risk tends to go down over time. You're right that we have those implemented those measures to reduce infection. When those measures was implemented was like 2 years after the trial start, and the vast majority of patients had already passed the first 6 months, which is the period when they had the most infection. So I agree with you. If you were to do this trial again, we'll probably see even lower rate of infection and severe infections and fatal infections, nevertheless. So I cannot overstate the importance of having those measures in place. And we do universal IVIG, PJP prophylaxis with trimiprazole, sulfamethoxazole. We do antimicrobials for the first month, and we do universal VZV prophylaxis. But with those measures in place, I think this is a very, relatively easy to give, very patient-friendly regimen that can sustain, as you can see, remissions for a very, very long time, and perhaps for some patients an indefinite period of time. Of course, there are trade-offs between, efficacy and safety. And I think we pay a lot of attention to the safety just because you have so few, progression events, right? That's why we do, overall survival analysis, respective of causality, which helps put in perspective how that excessive risk of infections, including fatal infection, compares with the major threat that those patients are under, which is the threat of progression and death from myeloma, which is still much, much, much higher on the control arm. I think the other, to me, at least in the U.S. context, this trial essentially advances bispecific T-cell engagers to from being a boutique specialized therapy to be administered only in dedicated myeloma centers, to be a therapy that can and should be widespreadly used, because now you're talking about the greatest impact we have seen in relapsed refractory myeloma for any therapy already on the second line. So if anybody out there who intend to treat myeloma needs to be familiar with this therapy, needs to feel comfortable administering this therapy. Otherwise, you really will be doing your patient a disservice, because you're going to be, skipping or looking in the other direction when you have a therapy with such a profound impact in progression-free survival and overall survival. I mean, the U.S. healthcare system, we still have this, duality between academic medical centers and community practices. And for us, this is the study that really say, anybody in any practice, if you're treating myeloma beyond first line of therapy, you need to be comfortable administering these therapies. The other part that I think was reassuring, in some ways surprising, is a lot of the perceived complexity and some of the reluctance of using bispecific T-cell engagers has to do with cytokine release syndrome. Well, when you look at data like this, essentially 40% of patients had no problems. 44% of patients had grade 1 CRS, which was fever. Okay? And we had 1 in 6 patients who had grade 2, which is fever plus, transient hypotension, transient hypoxia. So I don't believe this, becomes a specialized, toxicity that can only be managed by the utmost expert or an advanced cellular therapy center. Now, this becomes something that can and should be managed most of the times outpatient, so long people have access to corticosteroid and tocilizumab. It's really remarkable and often go understated that not a single patient died or got severely ill from CRS. So I think it's demystify that toxicity a little bit from the perception that we had before from early trials.
Thank you. I think those were very important comments which you made. Now we have an Indian expert, Dr. Riaz Ahmed. So Dr. Riaz, what do you think about this kind of a triple therapy? I would not say it's a doublet because you also have to supplement IVIG. So practically it is a triplet therapy. And what do you see since both the drugs are available in India? So what are your comments? And if you have any questions for Dr. Costa?
Good evening, Dr. Costa, and good evening, Dr. Pankaj. Thanks for the invite. Majestic 3 trial, I am also very thrilled about this. It's very good. As we say, 85% is the response rate. I don't think so any trial has shown this much of response in 1 to 3 lines prior therapy. In India, yes, because we are dealing with those subsets of patients who can afford 1 time of therapy, maybe 1 or 2 time of therapy. So any treatment which can give a good PFS in majority of the patient, I think so. This is very much excited about that. This patient, this group of patients actually, if we have in India, it will be a game changer for us. Patient may not have to go for multiple line of chemotherapies, and even after first relapse, which we are using quadruplets, and if we are going for the on the relapses, first relapse, if you are going for teclistamab and dara-based therapy with immunoglobulins, although little costly. I'm sorry, but I think so. That's the way to go. Rest all the therapies we can keep it aside. In Indian scenario, at least the first line setting, we can after first line setting we can go for this, especially given the way the responses are showing. Immunoglobulins will be very useful. I think so. We should not be waiting. I think so. It should get incorporated. Given this, both the Darzalex and the teclistamab is causing hypogammaglobulinemia, so this should be incorporated in the every cycle and to reduce the infections. As we saw initially, I think so the curve went down because of the COVID-19, which Dr. Maria was explaining. But after that, things have been pretty well. So we should have our own data how these patients coming up. How they are doing it in our scenario, especially the high-risk cases. I think so. This is the way to go.
Thank you. So it is open for discussion. So any questions from any of the audience? If there are any questions, and till the time we get the question, Dr. Costa, can you have the follow-up of some of these patients who are off therapy? And how are they doing? Or, can you say that some of them are functionally cured with this form of therapy?
Yeah, that is, I think, is a bit of a fine line there. I don't believe in claiming cure with people who are on therapy. So in this trial, I think you can see one limitation is that it plans treatment until progression. So, when you look at that PFS, it's tempting to to hypothesize that most of those patients or many of those patients might not require any different therapy for their for the remaining of their life. But the fact is they are on therapy, right? I think when we see data like this, we need to start exploring finite therapy so we can really have a shot at calling this a cure. We have trials in the newly diagnosed setting with this combination where treatment is finite. So we hope to learn a little bit more about that. And there are other initiatives about exploring this regimen or similar regimen for a limited number of cycles and then observing patients. Anecdotally, I have quite a few patients from this program or other programs who stop therapy for one reason or another, and the durability of responses are really remarkable. There was, I think, some report at IMS from a colleague from another site who pulled patients from multiple institutions who discontinue a BCMA T-cell engager. And if I remember correctly, after 1 year, still over 80% of those patients stay in remission. So I think I share with you that this, of course, demonstrates the safety and the efficacy of this combination. Does not answer the optimal duration, which is probably not going to be forever.
Yes, thank you. Dr. Sumit?
Hello, sir. Am I audible?
Yes.
Hi, good evening, Dr. Costa, and thank you, Dr. Ferran. So my question was, in the table one, when you look at a median time to complete response, median time to CR, it was exactly the same in both the arms, 6.9 months, 6.9 months. We expect that in teclistamab arm, it will be much earlier, even if we see with teclistamab monotherapy in relapsed refractory settings. Why was it exactly the same?
Yeah, I mean, this data is a bit hard to interpret because you're not looking at everybody. You're looking only at those who respond, right? So if you are among those who obtain CR on DPD or PVD, or sorry, DPD or DVD, yes, it took you 6 months. The same for Tec Dara. So I don't think that data tells you the speed of response, to be honest with you. Because if you start with a patient who has 1 gram of or more of an IgG paraprotein, the time to achieve immunofixation negative CR is going to depend more of the half-life of the paraprotein that will depend on the clearance of tumor, right? So we see this all the time with CAR T. We deliver CAR T. 1 month later, people are MRD negative. It takes then 6, 7, 8, 9 months to become CR because it takes forever to clear the paraprotein. So I think that data is really hard to interpret. I would not take that data as indicative of the speed of response. Responses with those regimens are very quick. I think if you were to look at, for example, light chains at the end of first cycle, you would see a dramatic difference between the two arms.
And if I could add one more question, in this study, in a supplement, you did not have the post-progression therapies. So how many in the control arm receive anti-BCMA therapies if they progressed on DPD?
That's a great question. We don't have that data yet. That has something that we all have been asked the sponsor to pull out. I don't, because this was a global trial. Most of the accruals were extra US in places where access to a BCMA-directed CAR T or TC might not be immediate. I suspect not a lot of patients, but I don't know that for a fact. I know all my patients got it, but that was a very unique situation.
Right. Any more questions? There is one question from the audience, which is kind of a little bit hypothetical at this point of time. If teclistamab moves to the first line, would you choose single agent teclistamab or along with Dara?
Well, I think the probably in combination with an anti-CD38 monoclonal antibody. I think the data. I think the data for Dara in a Dara naive population, or let's just be generic, an anti-CD38 and an anti-CD38 naive population, is very compelling. You have a multiplicity of trials in different populations and different settings with PFS and OS advantage, right? So it's hard, and is a drug, as a class of drug that adds a lot of efficacy and adds little toxicity, the anti-CD38. So it's hard to abandon that for whatever reason. Now, what we saw here with TechDARA, I think is really suggestive of a strong synergy. And after this data, I'm more and more convinced that those drugs, 1 + 1 does not equal 2. It probably equals something like 3. That those things are really synergistic. So I don't see any reason to abandon DARA in a population that has not received an anti-CD38 monoclonal antibody. And that applies to second, third, fourth line, but certainly would apply as well for first-line therapy. The data that we have so far with TechDARA upfront was data presented at the ASH from the IFM 2021 trial. That's a older, non-transplant eligible, more frail patient population, yet 100% survival. All patients amenable to MRD testing were MRD negative, and the PFS and OS curve, with a very short follow-up, nevertheless, is essentially flat at 100%. So hard to argue with that. The real question becomes, if you have a patient who has received anti-CD38, or let's say is anti-CD38 refractory, there's still any benefit to add daratumumab? And that question we don't have an answer for. There's hypothetical mechanism of how it could be helpful. Just last week, we saw the data, or a snip of the data, presented in a press release about MajesTEC-9. That trial was patients all anti-CD38 exposed who were randomized to TEC monotherapy versus KD or PVD. And that trial also shows a tremendous advantage in progression-free survival and overall survival. So we're going to learn a little bit more when we deep dive into that data, when that becomes publicly available. But it's still not going to give us the answer, what DARA adds to a CD38 refractory population, because that was not represented in MajesTEC-3, and they didn't have DARA on MajesTEC-9.
Thank you so much, Dr. Costa, for accepting our invitation and part of this journal club. We have another 15-20 minutes of second session where we have the Eagle Eye competition, and we discuss about another article, and it would be carried by Sumit Singh. So you can continue to log in, or it is up to you if you want to log off. But thank you so much.
But appreciate the opportunity. Thank you so much.
And again, congratulations for such a wonderful trial where nobody has heard of this much of response rate with hazard ratio of 0.17. Congratulations for that. Over to Dr.
So much.
Are my slides visible?
Not yet. Yes, now they're visible.
Okay. So the journal scan article for this month was a recent article published in Blood Cancer Journal, a very practical article which we have facing in a real day-to-day scenario, optimizing lenalidomide therapy in renal impairment patients, analysis of renal response in the prospective REMNANT study in transplant-eligible newly diagnosed multiple myeloma. So just to enumerate a process for those who are new to this, a recently published article is chosen. We invite a commentary of 175 words or less before a deadline. Anybody, irrespective of designation, with an interest in the field of plasma cell neoplasms can send a commentary. The best commentary is selected by a team of blinded reviewers, and the winner gets a chance to present a journal scan, a certificate, image credit hours, and lifetime membership also. The intent is that the junior faculty and residents should read the latest articles, learn the art of critical appraisal, refine the art of scanning an article. This will promote more letter to editors from our country, and at the same time, get an opportunity to present in front of a relevant audience. So how we analyze, these are the 5 parameters. First, the word limit of 175 words. This is very important, not in one word beyond that. Language, study interpretation, conclusion, and importantly, in the era of AI, plagiarism. So if there is any AI-based text, that is also caught by our team of blinded reviewers. So first of all, I would like to thank our reviewers for this month, Dr. Aditya Jandial from PJ Chandigarh and Dr. Nikhil Krishna Haridas from Amrita Hospital, Kochi. A special mention before I announce the name of the winner is Dr. Adarsh Patil, who was a close second behind the winner. He is a DM resident pursuing medical oncology first year in AIIMS Jodhpur. He has won the Eagle Eye few months back, and this was a close finish this time for him. The winner for this time is the first time Dr. Paras Gupta. He is pursuing his DM in clinical hematology at Postgraduate Institute of Medical Education and Research, Chandigarh. So, heartiest congratulations, Team PJ and Dr. Paras Gupta. I would request the MySideS team to play the recorded commentary. I'm not able to hear any audio. Can you please replay it?
Yeah, sure, sir.
Good evening, everyone. I would like to thank Image to give me this opportunity. So the topic of today is optimizing lenalidomide therapy in renal impairment, analysis of renal response in prospective remnant study in transplant-eligible newly diagnosed multiple myeloma. Renal failure is the second leading cause of death in newly diagnosed multiple myeloma with the highest chance of mortality in the first 6 months. 20 to 40% patients have renal impairment at the time of diagnosis. Rapid renal recovery is associated with improved clinical outcomes. Lenalidomide is in the standard induction therapy and require renal dose adjustment as per the FDA recommendation. Dosing strategy. As per recommendation, if eGFR is less than 50 ml per minute, low dose of lenalidomide is used. But in remnant study, if eGFR is less than 30 ml per minute, then the low dose of lenalidomide is used. Aims and objective to study the safety and tolerability of high lenalidomide dose, renal response during the induction phase, and to determine the overall response from cycle 1. This is the International Myeloma Working Group renal response criteria. It is complete response, partial response, minimal response on the basis of improvement in creatinine clearance. Methodology. This is an open label phase 2 prospective multicentric trial in 13 institutions across the Norway conducted between August 2020 to September 2024. Study group ages 18 to 75 years, transplant eligible newly diagnosed multiple myeloma patient. Patient have measurable disease and patient receive more than one cycle of induction phase are excluded from the study. During induction phase, patient receive 4 21-day cycles of bortezomib, lenalidomide and dexamethasone. Now result. 382 patients are enrolled in the study. 79% patient of eGFR more than 50 ml per minute are in group A. 10% of patients with eGFR between 30 to 49 ml per minute are in group B, and 11% of patients with eGFR less than 30 ml per minute are in group C. Baseline characteristics. Median age is 63 years in both the group. Patients without renal impairment have better performance status, and 52% of patients with renal impairment have light chain only disease. 75% of patients with renal impairment have involved-free light chain more than 500 milligram per liter. 68% patients with renal impairment have bone marrow plasma cell more than 50%. 23% of patients with renal impairment have hypercalcemia as compared to 7% patients without renal impairment, and 84% of patients with renal impairment presented with anemia as compared to 43% patients without renal impairment. 80% of patients with renal impairment are in ISS stage 3, and 46% patients with renal impairment are in RISS stage 2 and stage 3. Safety. Cytopenias are common in patients with renal impairment. 12% of patients with renal impairment develop anemia compared to 2% patient without renal impairment, and 7% patient develop thrombocytopenia compared to 0.3% in other group. Peripheral neuropathy and rash are common in patient without renal impairment because of receiving high dose of lenalidomide. Worsening of renal function only in patient with baseline renal impairment. Grade 4 worsening of renal function in 2 patients of group C, and grade 2 worsening of renal function in 2 patients of group. Renal response. Among 81 patients with renal impairment, 62 achieve an overall response. And among these 62 patients, 46 patients achieve complete response. Patient become dialysis independent in 5 out of 7 patients. The remaining 2 patients were died because of pneumonia and progressive disease. Overall response rate, which is partial response or better, were comparable across the group, which is 89% in group A, 95% in group B, and 82% in group C. If you're talking about reduction in serum free light chain, there's a significant reduction in the serum free light chain in all three groups from 299 to 0, 1712 to 0, and 2000 to 0. Now we're talking about adverse effect. Progression of the disease in 13 patients, 9 in group A, 2 patients in group B, and 2 patients in group C. 5 patients died, 3 patients in group A, 1 with the cardiac arrest, 1 with infection, 1 in failed chest, and 2 patients in group C because of the infection. Now we are talking about the limitation. It is a non-randomized trial without a comparator arm. No lenalidomide pharmacokinetics were studied. Relatively small renal impairment subgroup and no long-term follow-up data. Now we are talking about strength. It's a prospective study of high lenalidomide dose. It challenged the conservative lenalidomide dose in renal impairment subgroup, and the most importantly, it includes the patient on dialysis in their study. Critical points. Multiple myeloma patients with renal impairment were excluded from most of the clinical studies, so that subgroup is understudied and undertreated with low dose of therapy. So this study addresses a clinical evidence gap in renal impairment group. High lenalidomide dose is safe and effective, and there is an acceptable safety profile in severely ill patient, even patient on hemodialysis. The immunosuppressive action of high dose of lenalidomide need to be studied because there is an increased risk of infection in lower middle income countries. Thank you.
Thank you, Paras, and congratulations once again. So the next month Journal Club is on 25th of February 2026, and the Journal Club article will be a very recently published article on high-risk genomic consensus validation for patients with newly diagnosed multiple myeloma using next-generation sequencing. So it was published a few days back from the French myeloma working group, and it raises important eyebrows whether it's time to bid adieu to fish, especially in the era of genomics. The journal scan article for the next month is an Indian article or an article from India, multiple myeloma in young adults, insight from a tertiary cancer care center in India, published last month from Tata Memorial Hospital, Parel. Moving on to the quiz, and over to Dr. Uday. Thank you.
Good evening, all. Hope you are able to see my slides.
Yes, sir.
Yes.
Thank you. So I would request all the people who are currently online to kindly scan the QR code. If at all, if you are not able to scan the QR code or you are using a single device, so you can just log into get into your browser, type slido.com and put the gaming code 3226,452. It's going to be absolutely simple quiz. 5 or 6 questions on whatever we have discussed till now, whatever has been highlighted by the national and international experts. And those who do not want to reveal their name, you can just use abbreviation, you can use a mobile number, whatever. We request others to join as well, please. We wait for another 15 seconds before we start the quiz. There is no compulsion in writing your name. If at all, if you are shy of revealing the name, so you can just go ahead with whatever abbreviation. It's perfectly okay for us. Sure. With that, let's start off with a quiz for the day. It's going to be just 6 questions, very basic. So here comes your first question. Teclistamab is a bispecific antibody. According to Majestic 3 study article, which 2 target does it bind to? Okay, perfect. So as most of you have answered it correct, so it's on CD3 on T cells and BCMA on the myeloma cells. So that's the right answer. So with that, let's get on to the second question. So this is a way the teclistamab molecule is. So it's like a linker molecule which combines, brings together the T cell and the myeloma cell together by binding these 2 targets. Okay. So with that, let's get on to the next question. So are we ready? Here comes the second question. What was the primary endpoint of Majestic 3 trial? In fact, Dr. Farhan Naim had beautifully shown these graphs and the various aspects, and he has discussed all 4 of them. Okay, correct. So it's the PFS which was discussed, and that was the primary endpoint. Now, people need to understand, though the article talks about rate of complete response, in which, in fact, this is what Dr. Sumit asked the first author. So they spoke about rate of complete response, which was around 6.2 months. They spoke about PFS. They spoke about OS, which was not very different. The graphs were not separating too much. And they also spoke about MRD negativity. But in a particular trial, the sample size is always calculated based on the primary endpoint. So in this particular trial, they took PFS as a primary endpoint. So they calculated their sample size based on the PFS. Okay. So let's move on to the next question. According to the discussion in Majestic 3, what is the proposed mechanism for the synergistic effect between teclistamab and daratumumab? There was a slide on this by Dr. Farhan Naim. His 4th or 5th slide exactly spoke about this. Okay, most of you have not answered it correct. So primarily what daratumumab does is it depletes the immunosuppressive T cells. So when the immunosuppressive T cells are depleted, so the cytotoxic T effect increases, and that's how the teclistamab works. So when you give combination of daratumumab and teclistamab, it enhances the teclistamab's T cell mediated killing technique. So that's how they have a synergistic effect. Now, most of you have answered it as teclistamab increase the expression of CD38. No, it's not so. It's in fact the daratumumab which makes the teclistamab more effective, not teclistamab making daratumumab more effective. So it's the vice versa which occurs in this situation. Okay, so let's move on to the next question. The remnant, the trial which was discussed in the journal Scan. So they used a particular Len dose in patients with renal impairment for less than 30 ml per minute per 1.73 meters square. What was the dose? Okay, there is a divided opinion. So people have given 7.5 and 15. Now, generally, most of us in our routine practice, in our transplant eligible NDMM patients with renal impairment, we use either 7.5 or 5. But in this trial, they used a dose of 15 milligram per day. So they had used a higher dose. in the remnant trial, not 7.5 milligrams. Let's get on to the next question. The sub-analysis of remnant study showed that certain adverse events were significantly more common in patients with baseline renal impairment. What is that pair? Yes, most of you have answered it correct. So it's anemia and thrombocytopenia, which is much more common. Yes, 23% of you have answered worsening renal function. I agree that in the remnant, they also spoke about 5% versus 0% renal impairment in the two arms. But when we said the pair, GI disorders was not much different. So anemia and thrombocytopenia, there was a classical difference in both the groups. So that was very common in the patients with baseline renal impairment. Now, let's go on to the last question. In the MajesTIC trial, what was the estimated 36-month PFS in teclistamab dara group versus DPD-DVD group? This was a graph which had a huge difference. And that's what was harped upon by Pankaj sir also again and again, that this is one of those trials with a huge benefit. Yes, most of you have answered it correct. So it's 83% versus 29%. So with a beautiful hazard ratio that has come out with. And as Professor Rayaz said, there was no another trial wherein they have shown such classical difference between the two arms. So there was a great benefit of using teclistamab with daratumumab upfront in the form of PFS, though the benefit was of OS was not yet, the median OS was not yet reached. And there was a slight difference in the CRS with not major infections, though it needs to be evaluated in real life scenarios or in the real world studies. But at least this trial really shows that a combination of teclistamab and daratumumab can really do great wonders. So with that, let's get on to the leaderboard. Okay, so we again have Dr. Shikha as the winner, and she has answered all 6 out of 6 correct, followed by a close second with Shivangi Sharma and Dr. Rachit. So heartiest congratulations to all of you. Dr. Shikha is from AHRR. And the most difficult question wherein hardly anybody answered or only 22% got the answer right is the proposed mechanism for synergistic effect between teclistamab and daratumumab. So with that, heartiest congratulations, Dr. Shikha. As last month we gave you the image, I think membership. This month we are going to give you the IMS membership as the first prize. So I hand over the stage back to Pankaj sir for the closing remarks.
Okay, thank you so much, Dr. Sumit and Dr. Uday. And yeah, quiz is also, always interesting. We had more than 150 participants, and but I could see only 16 people participating in the quiz. I wish, this is fun. You should enjoy, this quiz. And it's unless you participate, only then you can enjoy. You cannot enjoy by just looking at it. So it is very interesting. Hopefully I would like to see more participants participating in this quiz. And with that, I thank you very much, Dr. Riaz, Dr. Costa, and Dr. Fian, who presented the article, as well as the team from Mice Ideas for making this journal club possible. So thank you so much. Thank you, everybody. And until next time, see you on 26th of February, I think.
Yes, sir.
26th
Yes, sir.
of February. Right. Thank you. Thank you so much. Jai Hind.
Jai Hind, sir.